Hello and welcome. My name is Elizabeth Wade, and I have shared a short summary of my professional background at the end of these slides. The title of this presentation is Successful Implementation 1, Organizing Changes and Key Stakeholder Engagement. This is the relevant financial relationship disclosure for this presentation. These are the learning objectives that will be addressed during this presentation. These are the key abbreviations that will be used during this presentation. By the end of this presentation, you should be able to answer the following self-assessment question. Which one of the following is not required for successful implementation of medication safety improvements? Is it safety change organization, key stakeholder engagement, project planning, clear and frequent communication or education, food provided at the kickoff, recognition and closing the loop, or monitoring and assessment? At the end of the presentation, we'll return to the assessment question, and I'll provide the answer and discuss the rationale. We've done a lot of work to date to learn about how to review and investigate errors, identify safety improvements, identify contributing factors. We talked about developing risk reduction strategies for each of those contributing factors, but none of this will actually impact patient care unless we successfully implement the change. So this is where the rubber hits the road for medication safety. Welcome to successful implementation. We know that successful implementation requires a lot of factors. First and foremost, there's going to be a lot of medication safety improvement opportunities. Safety is insatiable. How do we figure out what to prioritize and what to work on first? A process for organizing the changes and improvements, change management, is extremely important to ensure that we're prioritizing the impacts that have the most significant impact on patient care first. Second, we need to engage key stakeholders. The last thing we want is to have a change impact a stakeholder somewhere in the organization and produce an unintended consequence. Project planning is important to ensure that the project moves along and the improvement doesn't hit any roadblocks. We need to keep key stakeholders in the loop with clear and frequent communication, as well as provide education for staff that are implemented or that are impacted by the change. We need to recognize and close the loop for the error, and we need to monitor and assess the effectiveness of the change. If any of you happen to be doing work in medication safety, you may be asking yourself whether you're overwhelmed with the number of improvement opportunities. It's job security, right? Well, this is where change tracking and change management of safety improvement work comes in. Change tracking offers a valuable way for us to organize and stay on top of our changes. There's several purposes to this. One, by organizing our changes, we won't always feel like we're flying by the seat of our pants. We'll have everything in order. We'll include where the improvement came from, when we created the improvement, and so then we can track how long that idea has been open. We can track when the completion date is and whether it's on target, so we can provide status and updates. We can talk about the type of improvement. We can look at the safety impact to help us prioritize how important this improvement is compared to others. We can sort changes by the owning team, provide any relevant links or tickets, and also include a link to the original error or case, or cases. This is helpful in the form of a spreadsheet so that we can actually organize all of these changes in one location. I found this enormously helpful, especially when meeting with various owners of changes, for example, informatics. If you're meeting with an informatics team, you might be able to then filter all the changes that have to do with that team so that you can follow up with that team on a regular basis on the status of some of the changes. It's also helpful when you want to see the changes that have actually been implemented. Sometimes there might be so many things going on that it's hard to keep track of what's actually been completed. By tracking the ones that are still open and following up, you may be surprised that some of these changes do get completed and that you have some things to celebrate. And finally, change tracking helps to ensure that you're celebrating the improvements that get implemented and looping back and providing recognition to all of those involved, including the original reporter. This is a very high-level example of a change tracker that I've used in a previous organization. The idea is for you to be able to develop your own version of a change tracker that works for you. The key elements that I found to be successful are including the date in which we open a change, tracking the status, what the change description is, links to specific tickets, and then who's owning the change. I've also found it really helpful to document here what the strength of the change and how we want to prioritize that change is relative to others. That way, all of my changes are in one place, and when I meet with various stakeholders, I can filter this sheet down to just the changes that I want to talk with that team about. It's also a great way, once it's completed, I can track it here and have all of the celebrations of the improvements we've implemented in one place. So I hope you take this opportunity to organize all the changes that you have in your organization. When we embark on any medication safety improvement, it's important to engage key stakeholders up front. With any change, large or small, we want to understand, why are we doing this? What's the call to action? Are we doing this because of a medication error? Are we doing this proactively because it's a best practice from the Institute for Safe Medication Practices or a guideline? Is it a regulatory requirement? Did we see a sentinel event in the news? There's got to be a call to action and a fuel to the fire for why we want to make a change. We also need to understand who is most impacted by this particular improvement. We need to first engage with those people. Finally, we need to have a clearly defined call to action that we communicate to everybody. We need to set our purpose, a North Star. This will help us whenever we need a tiebreaker on a decision that's conflicted. The why is going to be used for buy-in, for staff education, and for our elevator speeches and leadership discussions. To illustrate the call to action, I'm going to use some work we did to implement the ISMP Targeted Medication Safety Best Practices for Hospitals number 3. This is about weighing patients. In this best practice, it is recommended to weigh each patient as soon as possible on admission and during each appropriate outpatient or ED encounter. It is recommended to avoid the use of a stated, estimated, or historical weight. And it's recommended that we need to measure and document patient weights in metric units only. When we first formed the group, we identified all the key stakeholders who are actively involved in the weighing of patients. This included ED staff who use stretcher scales, clinic staff who weigh patients who come in for their clinic visits, inpatient staff who may have patients who use bed scales. We included the biomedical engineering team who is in charge of the maintenance of all the equipment, and dietitians who are in charge of keeping track of weight for nutrition purposes, as well as pharmacy staff. Obviously, we also included providers who need to use weight information to prescribe appropriately. This whole group gathered together to develop a call to action and brainstorm the why behind what we were doing with patient weights. In this example, we said the hospital was harming patients due to missing or erroneous patient weights. They are at continuous risk for dosing errors and nutrition support errors, and the wrong choice of equipment. The hospital staff face rework when confronted with these situations. We had weight-related comorbidities that resulted in inappropriate use of resources, longer lengths of stay, readmissions, and poorer outcomes that negatively affected the hospital's risk-adjusted acuity index. Because of this, there were financial implications and risk liabilities due to inconsistencies in medical record documentation and coding that could later incur regulatory penalties for meaningful use. An accurate and measured weight in kilograms on admission is a current ISMP best practice and patient safety goal. These are all great reasons for why we're here to do what we're doing. Now, I talked about how we included all those different departments and stakeholders, including biomedical engineering. How did we figure out who to include? It's literally impossible for any one person or department to be aware of every possible stakeholder in an organization for an improvement. That's why it's important to leverage your resources, leverage your connections. Existing decision-making groups and committees like P&T or medication safety committees are a great place to get feedback on who should be involved. You can also seek feedback from any change management groups or governing bodies, and leverage and meet with organizational leaders to discuss any stakeholders who need to be included. For complex projects that engage many stakeholders, tools such as a RACI model can help to organize communications and expectations. The RACI model is a great way to organize roles and responsibilities for any activity or group of activities. In the RACI model, you develop a matrix or a spreadsheet. In the spreadsheet, the rows consist of the list of tasks and responsibilities for the project. In the columns, job functions and titles of each of the stakeholders are included. And in each cell, we would include the letters R, A, C, or I, R representing that that person or job function is responsible for the given task, A being that the person is accountable for the task, C that that job function is consulted for the task, and I that that job function is simply need to be informed of the task. I know I went over that pretty quickly, so what does that actually mean? What does it mean to be responsible versus accountable or consulted or informed? Well, to clarify, being responsible is the person who actually needs to do the work. So every task has to have at least one job function or person who is actually responsible for the work getting done. Accountability is a little bit different. The person ultimately accountable for any work or decisions made isn't necessarily the one completing the work, but they might be overseeing it or the ones held accountable with leadership. There can only be one accountability, or A, in each row. For C, anyone who needs to provide input prior to a decision or task being completed is consulted. There can be a lot of C's in each row, and for complex projects, there probably should be. And finally, I, someone just needs to be informed of a task. They might not necessarily need to be consulted, but this is where someone just wants to be kept in the loop when something's done. There can be many I's in each row as well. This is a somewhat simplified version of the RACI model that we use for our patient weight project. You can see that along the top, we have different people, including the Director of Nutrition, myself as the Medication Safety Officer at the time, nursing leaders, LNA leaders, outpatient leaders. We had pediatrics represented, a chief officer, risk manager, and biomed. You can see that there's some example tasks here. Now, these certainly don't comprise all of the tasks related to this project, but just a few to give you an idea. For example, for the first row, we needed to draft a patient weight policy. Well, who was actually going to complete and draft the policy? Certainly not the frontline staff or the chief officer, but it was going to be the nutrition director, myself, and the director of nursing who were going to be drafting that policy on patient weight together. We needed to consult all the people on the front line, though, and the nursing leaders and all the outpatient leaders who complete the work. So all of those people are consulted. The chief executive officer or chief nursing officer, medical officer, what have you, was the one who was accountable for making sure that that weight policy was developed. We had risk managers and biomed that needed to be in the loop that that was being developed, but they didn't necessarily need to be consulted. Similarly, you can see how we established standard scales, developed staff education plans, and developed patient and public education plans. You can see under each role, we've designated responsible, accountable, consulted, or informed based on the appropriateness of that role and how they need to engage in that task. This RACI model is really useful for not only getting your task organized, but also making sure you're engaging your stakeholders in the right way. This prevents gaps in communication for change management. I recommend, as one of the initial steps after the call to action, is to review and approve a RACI model so that all the stakeholders right at the beginning of the project are on the same page. This will help to ensure that no gaps in communication occur and that everyone receives communication and is kept in the loop as needed. Now let's go back to our self-assessment question. Which one of the following is not required for successful implementation of medication safety improvements? Is it A, safety change organization, B, key stakeholder engagement, C, project planning, D, clear and frequent communication or education, E, food provided at kickoff, F, recognition and closing the loop, and G, monitoring and assessment? If you answered E, having food provided at the kickoff, you would be correct in that it is not required, though always very much appreciated by key stakeholders involved in a medication and safety improvement project. In conclusion, successfully implementing risk reduction strategies is where the rubber hits the road for medication safety. Having a method for organizing and tracking your improvements and changes is essential for medication safety leaders to prioritize the right changes at the right times. The RACI model is a great way to engage stakeholders and ensure the appropriate level of communication for everyone involved. These are the references used to develop this presentation. Thank you very much for your time and participation.